Good morning. Good morning, everybody. I'll be presenting to you about our 40-year-old no loss of appetite. She is a non-smoker and had biomass fuel exposure for over 26 years and pigeon dropping exposure for over 5 years. On examination, she had Velcro crepitations on the left side and was positive and she was negative for COVID testing. And on chest radiograph, which was done at the initial time of evaluation, she had ground glass opacities and reticulations involving the left, mid and lower zones. And the CT scan done at that point showed diffuse ground glass opacity with cystic lucencies in the left hemithorax and to a lesser degree of involvement on the right side, which I will come to eventually. She had received inhalational and oral corticosteroids and had not shown any significant improvement and was referred to CMC for further evaluation. And in the HRCT, which was done here in CMC, there was diffuse ground glass opacity with cystic air spaces involving the left, upper and lower zones, as you can see here. In addition to that, there was this peribronchial area of consolidation involved in the lingula. Similar pattern of involvement was also seen on the right side, but to a lesser degree. And on mediastinal window, there were no significant mediastinal nodes. And on comparison with the previous CT scan, which was done 7 months prior to this one, there was no significant difference between the two CTs. So we had a list of differential diagnoses, the first being chronic hypersensitivity pneumonitis. The fact that she had pigeon dropping exposure was a clue for that, and there was ground glass opacities. However, there were no areas of air trapping. Sarcoidosis, alveolar stage of sarcoidosis can also present with ground glass opacities, but there were no significant mediastinal nodes or nodules in the peribronchial distribution or the subpleural region that you would expect in a patient with sarcoidosis. Viral pneumonia was considered less likely because of the long-standing history and no improvement post-treatment. TB was also considered less likely as there were no classic signs like cavitations or consolidations or tree in bud nodules or mediastinal nodes. Malignancy was also considered as she had ground glass opacity with cystic lucencies and the small peribronchial consolidation. She underwent blood investigations which were unremarkable. Serum ACE levels were within normal limits and TB gene expert was traced. She had a transbronchial lung biopsy which showed florid atypical pneumocyte proliferation, and hence for deeper sections a CT guided lung biopsy was suggested, which showed a adenocarcinoma with lipidic and micropapillary pattern. When it was EGFR positive, the lung biopsy was taken from the lingular consolidation. A final diagnosis of disseminated malignancy in both lungs was made and she was offered treatment and chemotherapy. As her condition was not medically fit, so she deferred getting chemotherapy and she went on with gefitinib, which is a tyrosine kinase inhibitor. Literature review wise, lung cancer is a leading cause of cancer-related deaths in the developed countries, and early diagnosis is key to management. They can present with symptoms pertaining to the lung as such, or for any metastatic focus in the bones or in the neural invasion, or they can, in some cases, like in 10% of population, they can be asymptomatic at the time of diagnosis. Lung cancers can be histopathologically can be divided into non-small cell lung cancer and small cell lung cancers. And non-small cell lung cancers can be further classified into squamous, adenocarcinoma and large cell carcinoma. Small cell lung cancers are usually seen in smokers, so as is squamous cell carcinoma. There is an increase in predilection, there is an increase in the incidence of adenocarcinoma in the recent years, and so I'll be going in detail on that. Adenocarcinomas can be divided into pre-invasive and invasive patterns. Pre-invasive patterns are the atypical adenomatous hyperplasia and adenocarcinoma in situ. The other name for adenocarcinoma in situ being the bronchoalveolar carcinoma. The invasive patterns can be minimally invasive or invasive non-mucinous or invasive mucinous. So how do we differentiate this on histopathology? Pre-invasive patterns do not have any signs of invasion on histopath, whereas invasive pattern can be classified into minimally invasive and invasive patterns depending on the depth of invasion. Minimally invasive patterns have less than 5 mm depth of invasion. So this is just to show the pictorially how atypical adenomatous hyperplasia can present. They can present as subpleural ground glass nodules which are or less than 5 mm in dimension. And adenocarcinoma in situ are usually larger than this size and they can have some minimal solid component within them. However, there are no signs of invasion on histopathology and they are usually purely lipidic patterns. Invasive patterns can be minimally invasive and invasive, as I've already discussed. They can present with a different amount of solid component within the ground glass nodule, or they can be purely ground glass in density. And invasive patterns can be just the nodules as such, can be any pattern or internal bronchograms or cavitations. Adenocarcinoma, invasive mucinous variants can present with consolidation, which can be unifocal, multifocal or bilateral disease. Then we have some other variants less commonly seen being colloid and the enteric types. So what is the role of a radiologist in the evolution of nodules? On comparison, we should always see if there is an increase in the size of the overall nodule and the size of the non-solid component being increasing size, they can be decreased in the size of the non-solid area. So this is the size of the same nodule which has which is a part solid nodule. The size of the solid component within the nodule can be increased, or in some cases it could have started as a pure ground glass nodule with some with some part solid component which develops over time. They can be oval, they can be lobulated, or can have spiculated margins. They can be cystic in consistency, and some earlier the thing of calcifications being part of showing it to be a benign nature is not really true. Adenocarcinomas can also have such kind of calcifications. Cavitations can also be seen. So other mimickers of lung cancer include pneumonias, fungal infection like a pattern, pulmonary infarct like pattern, and scars. So volume doubling time can range anywhere between 1 month to over a year, and adenocarcinomas can actually be present for over 2.5 years of duration. Annual follow-up should be done at least for a period of 3 years, and past growth rate is not a predictor of future growth rate. And my take-home message would be that a radiologist should have a high degree of suspicion when dealing with a non-resolving ground glass opacity, which could represent a lipidic pattern of growth, and bubbly cystic spaces like how we saw in our case here. Having a low threshold to biopsy suspicious nodules and consolidations is also key to management, and they should be followed up for at least 3 years. And as I've already mentioned, past growth rate is not a predictor of future growth rate. These are my references.
Thank you. Does anyone has any questions? Okay. Were you surprised to see that the patient had an EGFR mutation and not like ALK or anything else?
Yes, sir.
Yeah. My second question, how is the patient doing now?
So the patient was here last in February and they are yet to come for review. So because they were not affordable, they have gone back to their hometown in West Bengal. So they are expecting them to come sometime now.
So suppose this patient will progress. So do you repeat a biopsy or you just declare it as a best supportive care?
So I think they have already declared it to be a palliative treatment for this patient.
Yeah. So there is a difference between palliative and best supportive. So
Okay,
if it is further progress, so you will do some intervention to pick up some new mutations, or you will say nothing is required as of now.
I'm not very sure of that, sir.
So EGFR mutated disease in today's time has a 5-year survival of in between 40 to 50%. So yes, if the patient progresses, you should be doing a biopsy. We should be looking for something called as T790M mutation, because if that is present, there is again a drug which can target and will give a response rate of around 70 to 80%.
Sure, sir.
Thank you. Nice and interesting presentation.
Thank you, sir.